Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, and I am doing a course on health and disability in humanities. Well, today I'm going to discuss the disabled body in modern medicine and culture, which is an important part of health or medical humanities. The contemporary interplay between medicine, cultural perspectives, and the experience of disability is characterized by a significant tension. On the one hand, there exists a biological imperative to address and correct physical differences that deviate from societal norms. On the other hand, there is a growing cultural movement that advocates for the celebration of individual identity and the rich tapestry of human diversity. Well, I'm discussing all these aspects related to disability because disability is also one of the important aspects of health humanities. How the society takes disability that depends on several factors. This conflict highlights the struggle between the desire to fix what is perceived as atypical and the recognition of the value and beauty inherent in variations of the human body and experience. Coming to the cultural repercussions and responses to this disabled body, we need to know that cultural narratives have historically mirrored medical paternalism, but contemporary movements offer sharp critiques and alternatives, and the first is narratives of tragedy. Mainstream media frequently reduces the disabled body to a trope, either a tragedy to be pitied or an inspirational object used to build character in able bodied peers. The second one is the social model championed by disability rights advocates. This model separates biological impairment from disability, arguing that people are disabled by inaccessible infrastructure, systemic exclusion, and stigma rather than their own flesh. The minority body, this is yet another important aspect. The philosophers and scholars like Elizabeth Barnes, author of The Minority Body, argue that a disabled body is not a defective or suboptimal body, but simply a minority body type facing social operation. Then, coming to the social model of disability. Well, as has been discussed earlier, this is a foundational framework in disability studies and activism that separates a person's physical or cognitive differences from the experience of being disabled. Developed by disabled advocates in the UK during the 1970s and 1980s, it states that society disables people, not their individual impairment. And the core distinction regarding impairment versus disability says that the model draws a strict line between two concepts. What are these two concepts? Impairment, a person's long term physical, sensory, cognitive, or psychological difference. That is, being unable to walk, being blind, or having autism. And the second concept is disability, the restriction, exclusion, or disadvantage caused by a society that fails to accommodate these differences. So, the key dimensions of social barriers related to disabled body under this model, it says that disability is not a medical problem to be cured, but a structural problem to be solved by removing three main types of barriers. Now, what are these barriers? The first one is environmental and physical barriers. Inaccessible architecture and infrastructure actively lock people out of society. An example that a person who uses a wheelchair is not disabled by their inability to work. They are disabled by a building that only has stairs and no ramp. Second one is attitudinal barrier, systemic stigma, prejudice, and low expectations create social exclusion. For example, a qualified deaf job applicant is disabled by an employer who assumes they cannot perform the work rather than by their hearing loss. Third one is systemic and institutional barriers. Policies, laws, and practices that exclude or fail to protect marginalized body. For example, a university that does not provide a screen reader accessible software disable blind students by locking them out of the curriculum. Coming to the medical model, well, modern medicine relies heavily on the medical model of disability, which views physical and cognitive differences as individual pathology. There are three primary elements of this model. First is the deficit framework. The disabled body is assessed strictly by how far it deviates from standardized biomedical norms of functioning. It is understood in terms of a deficit or lack from the normative functionality. Second one is the imperative to cure. Intervention focuses heavily on surgery, pharmacological management, and intensive therapy to shape the patient into a closer approximation of an able bodied norm. The third one is the unfinished body. Rather than reaching a fixed state of healing, the disabled body is often positioned as an ongoing medical project, constantly monitored, adjusted, and managed across a lifespan. So, the critic and nuance regarding the disabled bodies says that while revolutionary contemporary disability scholars note that the strict social model has limitations, critics argue that by focusing entirely on external barriers, the model sometimes minimizes the realities of physical pain, chronic fatigue, or bodily suffering that exist independently of social barriers. Modern framework often combine both perspectives to address environmental discrimination while still validating personal medical needs. They emphasize how the social and professional spaces can be improved to accommodate the disabled individual, along with taking into account the specific needs of the disabled. Let us discuss some of the dimensions of medical and social model. So, what are the dimension in medical model and what it says under social model? So, the problem, and in medical model, it is the individual's body, mind is broken, and the social model says the environment is unaccommodating. While the solution medical model says cure, rehabilitation, and normalization. The social model says universal design, civil rights, and inclusion. Under dimension, the goal, the medical model says makes the person adjust to society, while the social model says change society to fit everyone. Coming to the unfinished body narrative. The unfinished body narrative is a concept in medical sociology and disability studies that describes how modern medicine positions the disabled or chronically ill body as a perpetual ongoing project. Coined heavily in research exploring how disabled young people navigate healthcare, it highlights that within a biomedical framework, the disabled body is never viewed as completely healed or whole. Instead, it is trapped in a continuous loop of monitoring, surgical intervention, and therapeutic management. So, the key mechanics of the narrative is that the rejection of restitution narrative. In classical medical sociology, Arthur Frank identified the restitution narrative, which follows a simple timeline. I was healthy, I got sick, medicine fixed me, and now I'm healthy again. The unfinished body narrative directly rejects this binary. For individuals with congenital disabilities, chronic conditions, or permanent impairments, there is no past healthy state to return to and no final cured state in the future. But dominant ableist narratives possessed miracle cures or hypothetical bodily expectations, which affect disabled individuals not only mentally but also physically. Coming to the next aspect, that is the continuum of flexibility. The body is placed on a perpetual continuum toward an unattainable standard of non impairment. And the cycle is that a child might undergo multiple corrective surgeries, extensive physical therapy, and assistive device fitting. The outcome is that rather than achieving a permanent baseline, any clinical improvement is viewed as transient. As the body ages or changes, new flaws emerge that require further medical intervention. The body as a site of constant labor, because the body is seen as inherently unfinished. The individual must engage in continuous physical and management labor. This includes a strict adherence to medical regimens, exercising to prevent regression, and managing how their body appears to others. The fear of the body, failing or showing visible signs of deterioration, creates a constant pressure to perform normalcy. Intersection with emerging identity. As disabled individuals transition from childhood into adulthood, their personal aspirations change. The unfinished nature of their body becomes deeply tied to identity. They must balance their own developing selfhood with a medical apparatus that consistently tells them their physical form is incomplete and requires constant adjustment. Well, cultural and sociological impact by shifting the focus from a simple cure to an ongoing process, the unfinished body narrative reveals how medical paternalism exerts control over bodily differences. It highlights that the medical model can inadvertently trap individuals in a lifetime role of being a patient rather than allowing them to exist as a complete autonomous person whose body is already whole exactly as it is. The unfinished body narrative explores the psychological and physical burden of living under perpetual medical supervision, where a person is trapped in a permanent state of being a patient. While the social model fights external societal barriers, the unfinished body narrative looks inward. It examines how a person negotiates their identity when medicine treats their physical form as a lifelong, incomplete innovation. So, the key dimensions of unfinished body is the medicalization of development. For individuals with congenital or childhood onset disabilities, growing up means navigating a calendar dictated by clinical milestones rather than personal ones. Projected future. The pediatric care often focuses on preparing the body for an idealized adult autonomy that may not align with the patient's actual reality. On the contrary, the forced autonomization might harm the patient, leading to worsening of their situation. Coming to the interrupted identity of this disabled body, so childhood and adolescence are fragmented by repeated surgeries, clinical trials, and physical therapies, forcing the individual to build an identity around clinical recovery. The illusion of the final cure says that traditional illness narratives rely on a clear resolution, diagnosis, treatment, and recovery. The unfinished body narratives reveals that for chronic and disabled bodies, recovery is a marriage. Coming to the moving goalpost, Every successful surgical intervention or therapeutic milestone merely resets the clock, revealing a new bodily deficit that requires attention. The transient baseline stability is treated as temporary. The body is viewed as constantly at risk of regression, requiring ongoing maintenance to hold its ground. So, bodily autonomy versus clinical compliance, living as an unfinished body creates a tense power dynamic between the individual and the medical establishment. And the compulsory normalcy says that patients face intense pressure to comply with exhausting medical regimen to make their bodies appear or function more normally. Reclaiming the self, choosing to stop interventions, decline surgeries, or opt out of physical therapy is often pathologized by doctor as non-compliance, coming to the toll of continuous body labor, and the narrative highlights that an unfinished body demands constant work. The individual must manage medications, navigating insurance, monitor symptoms, and perform physical exercises to maintain their current state. This emotional and physical labor can result in clinical burnout, where the person must actively fight to see themselves as a whole, complete human being rather than a medical failure. So, reimagining representation covers that to counter clinical objectification, disabled creators utilize literature, performance art, and visual media to reclaim autonomy. Groundbreaking text like Rosemary Garland Thompson's Extraordinary Bodies examine how the physical anomalies displayed in historical freak shows evolved into modern cultural anxieties and literary archetypes. Modern culture shift demand disability cultural competence in healthcare, ensuring patients are recognized as active agents and co-experts in their own lives instead of their lives being dictated by the caregivers or able body individuals purporting to know better. So, disability cultural competence is a framework in healthcare and social services that requires providers to recognize disability as a unique, valid cultural identity. Rather than viewing a disabled person through a purely clinical lens, this framework demands that professionals understand the history, values, language, and systemic barriers shared by the disabled community. Integrating this competence into modern institutions bridges the gap between the external focus of the social model and the rigid constraints of clinical treatment. It brings about a more than cursory and performative awareness about disability by making people realize the cultural dimensions of disability, its invisibility in ableist spaces, and the normative impositions placed on disabled individuals. So, the core principles of disability cultural competence says that recognition of disability culture providers must understand that disability is not just a health condition but a vibrant cross-cultural subculture. And this unique identity says that specific communities, such as the deaf community or the independent living movement, have distinct histories, values, and languages. Interdependence over independence. Western medicine heavily emphasizes a patient achieving complete independence. Disability culture often flips this, valuing mutual support and collective care network. Shared history, acknowledging a legacy of institutionalization, social exclusion, and medical paternalism that helps to explain why many disabled patients harbor systemic distrust towards medical institutions. Next aspect is competent use of language. Language shapes clinical environments and determines whether a patient feels respected or objectified. Its competent uses include avoiding archaic terms, moving away from pathologizing language like wheelchair bound or suffering from a condition. Then, dynamic language choices, respecting the patient's choice between person first language, that is, a person with Down syndrome, and identity first language, that is, an autistic person, which is heavily preferred by many contemporary disability advocates. So, shifting quality of life assumptions says that healthcare professionals frequently fall victim to the interviewer's illusions, where they underestimate the quality of life and satisfaction reported by disabled individuals. And the bias is that a doctor may view an impairment as an unmitigated tragedy. And the competence is recognizing that a disabled person's life can be deeply fulfilling provided they have proper structural accommodations and social support. So, patient as co expert says that disability cultural competence upends traditional medical hierarchies by acknowledging that the patient has supreme expertise regarding their own lived embodiment. Clinical decisions are made with the patient through collaborative, shared decision making rather than being imposed upon them. Moving from competence to humility, many modern scholars advocate for pairing cultural competence with disability cultural humility. While competence applies a fixed toolkit of knowledge, humility requires a continuous lifelong process of self reflection, actively examining one's own internal ableist biases and recognizing that a clinician can never fully understand another individual's unique physical or mental reality. Coming to the medicalization of the medicalization of the body is a sociological process where normal human variations, experiences, and bodily functions are defined and treated as medical conditions, illness, or disorders. Under this framework, the medical establishment becomes the primary authority over what constitutes a normal or healthy body, turning ordinary physical differences into clinical problems requiring intervention. So, the core mechanisms of medicalization says the power of the biomedical norms. Medicalization relies on standardizing human biology into strict statistical averages. The deviant body says anybody that falls outside these constructed baselines, whether due to shape, size, cognitive function, or mobility, is categorized as pathologically deficient. Pathologizing natural processes says that universal human experiences such as aging, childbirth, menopause, and grief are increasingly shifted out of the social or natural realm and placed under clinical management. Then, surveillance and the clinical gaze. As described by philosopher Michel Foucault, the clinical gaze separates a patient's lived experience from their physical body. Objectification is the person is reduced to a set of symptoms, organs, or lab results. Constant monitoring is that through routine screening, diagnostic testing, and health tracking technologies, the body is placed under permanent medical surveillance to catch and correct abnormalities. Fifth is institutional control and expanding markets. Medicalization is driven by powerful institutional alliances between healthcare systems, pharmaceutical companies, and insurance corporations, creating conditions, broadening diagnostic criteria, expanding consumer markets by turning ordinary human traits into conditions that require lifelong pharmaceutical or surgical management. The individualization of social problems, systemic issues such as chronic stress from poverty or physical exhaustion from labor are often diagnosed as individual chemical imbalances, treating the body rather than correcting the toxic environment causing the distress. Impact on the disabled body says that when applied to disability, the medicalization framework dictates that the disabled body is a fundamentally broken mechanism. The imperative to fix it prioritize surgical alteration, pharmacological correction, and intensive physical rehabilitation over social acceptance and structural accessibility. The patient role says that it strips individuals of their bodily autonomy, forcing them to occupy a permanent patient role where their quality of life is determined how closely their body can be modified to mimic able bodied norms. So, consequences of medicalization of the body has profound consequences for the disabled body, fundamentally shaping how a person experiences their own physical form and how they are treated by society. By framing bodily differences strictly as health crisis or mechanical failures, medicalization alters the lived experience of disability across several key dimensions. And the loss of bodily autonomy says that when a body is medicalized, the authority over the body shifts from the individual to medical professionals. Enforced compliance. So, choosing to decline a surgery, stop a painful therapy, or refuse a medication, which is frequently pathologized as non compliance rather than respected as an exercise of personal choice. Coming to the burden of permanent patienthood, medicalization traps the disabled individual in a medical patient rather than simply a citizen. The project body is the body that is treated as an unfinished construction site that requires constant monitoring, adjustments, and interventions to mimic able body norms. The marriage of recovery, because many disabilities are permanent or progressive, the medical expectation of a cure creates an unattainable standard, leaving the individual in a state of perpetual clinical failure. The evaluation of non normative function says that under a strictly biomedical lens, any variation from a standard human autonomy or processing is viewed as a deficit. Pathologizing adaptations, natural adaptations such as a deaf person using sign language or an autistic person stimming are often viewed as symptoms to be eradicated or corrected. Assumption of tragedy. Clinicians frequently suffer from a bias where they underestimate the quality of life of disabled individuals, operating under the assumption that a disabled life is inherently a tragic one. Depoliticization of disability. By treating disability as an individual biological problem, medicalization obscures the social, economic, and political factors that actually restrict disabled people, treating the flesh, ignoring their stairs. Resources and focus are funneled into expensive surgical fixes for the individual body. Individual systematic barriers highlights the isolation and unemployment experienced by a disabled person who are blamed on their physical impairment rather than on a hostile exclusionary society. So, the medicalization of psychiatric disabilities, often discussed through the lenses of MAD studies and neurodiversity, shifts the focus from structural, emotional, and social distress onto individual brain chemistry. When mental, emotional, or cognitive differences are strictly medicalized, the impact on the individual mirrors and in some ways intensifies the pressures placed on physically disabled bodies. Key dimension of medicalizing psychiatric disability says the chemical imbalance myth and the fixation on cure. For decades, mainstream psychiatry relied heavily on the chemical imbalance theory to explain psychiatric condition. This has been repeatedly proven to be wrong. In addition, the fixation on finding a cure can result in dangerous treatments instead of aiming to accommodate the psychiatric disability. The deficit view says that variations in thought, mood, and behavior are treated as individual biological defects to be corrected rather than complex responses to trauma, environment, or natural cognitive diversity. Symptom suppression says that treatment focuses predominantly on pharmacological management to blunt symptoms and enforce behavior that mimics neurotypical norms, sometimes at the expense of a patient's overall well being or creativity. The loss of legal and bodily sanity highlights, unlike many physical disabilities, psychiatric disabilities can carry legal mechanisms that completely strip a person of their autonomy. Involuntary interventions. Under the guise of medical protection, individuals can face forced institutionalization, court ordered medication compliance, or chemical restraint. Epistemic injustice points out a person with a psychiatric diagnosis is often subjected to testimonial injustice, where their stated experiences, boundaries, or complaints about side effects are dismissed by clinicians as merely symptoms of their illness. Individualizing systemic and social distress, medicalization pathologizes the body and the mind. It puts the onus on the individual rather than their environment and social and professional structure, treating the mind, ignoring the environment. Chronic anxiety, depression, or trauma responses stemming from poverty, systemic racism, unsafe housing, or labor exploitation are diagnosed as internal clinical disorder. Depoliticizing suffering by framing distress as a personal medical problem, institutions avoid the responsibility of addressing the societal inequities causing or exacerbating the crisis. Coming to the rise of MAD studies and neurodiversity. In response to clinical paternalism, advocates and scholars have built alternative framework to reclaim identity. The first one is neurodiversity paradigm. This framework views conditions like ADHD, autism, bipolar disorder, and schizophrenia not as a broken brains but as naturally occurring variations in human writing that bring unique perspectives and strength. MAD studies, an academic and activist field that rejects psychiatric reductionism. It honors the lived experience of madness or distress, centering psychiatric survivors as the true experts of their own minds. Permanent patienthood highlights the burden of permanent patienthood as psychological, social, and logical toll experience by individuals with chronic or lifelong disabilities. It occurs when a person is trapped in a permanent state of being a patient, never allowed to simply exist as a whole, autonomous individual. This framework highlights that the modern medical system does not just treat the disabled body, it colonizes the person's daily life, identity, and future. So, the key dimensions of permanent patienthood speaks of the lifelong surveillance state for a permanently disabled or chronically ill person. The medical system is never optional. The other one is the constant monitoring. So, life is structured around an endless cycle of clinical appointments, diagnostic screenings, and laboratory tests. The bureaucratic tax navigating health insurance, securing prescriptions, and managing medical documentation becomes a full time unpaid job. The individual cannot step away from this labor without risking their health or survival. The mirrors of resolution is that traditional society views illness through an acute timeline. You get sick, you receive treatment, you are cured, and you return to normal. Permanent patienthood shatters this expectation. Perpetual unreadiness. Because the disability is lifelong, the individual is kept in a state of perpetual preparation for the next medical intervention. The burden of expectation says well meaning friends, family, and doctors often pressure the individual to constantly seek new treatments, clinical trials, or therapies, implicitly signaling that their current state is unacceptable. Infantilization and loss of adult autonomy. The role of a patient is historically passive, someone who takes direction from an expert clinical authority. And medical paternalism highlights when a person is an institutional patient for life, clinicians often stripe them of adult agency. These personal lifestyle choices, risks, and goals are frequently pathologized or overridden by medical protocols. The transition cliff, this burden is particularly acute during the transition from pediatric to adult care, where individuals must suddenly fight to have their adult selfhood recognized by an unfamiliar and cold medical apparatus. Identity fragmented by clinical categories says that when a person spent their life in clinical spaces, it becomes incredibly difficult to separate who they are from what their chart says. Colonized mind, the individual self worth, body image, and personal narrative become deeply entangled with clinical terminology and deficit based diagnostic. Reclaiming the self highlights breaking free of permanent patienthood requires a conscious, exhausting effort to build a life, a community, and an identity entirely outside the walls of the clinic. The liberation of shared vulnerability exploding, the myth of the one way street liberates both parties. For the caregiver, it removes the crushing, impossible pressure to be an invulnerable, self sufficient superhero who never needs help. For the receiver, it restores their dignity, validating that their existence holds immense value regardless of their physical or cognitive capacities. With this, I wrap up the discussion. Thank you.